So in patients of elderly patients with AF, which is a most common subset of AF in our population also, the problem with the elderly population is that they have a decreased GFR. Number one, they have more bleeding risk, and they are non-adherence, and also in view of this uh, pandemic like situations now, the access to frequent access to INR is not that common with the elderly population. So the Geriatric Society has recommended the dabigatran and rivaroxaban to be used cautiously. However, in real world data, the rivaroxaban has been shown to have a higher risk of GI bleeding, and in patients of creatinine clearance of less than 30, dabigatran has some lack of safety data. However, with the modified dosages, we can use in the geriatric population. Next slide. So this is a real world study from Europe, in which the risk of the stroke and systemic embolism with oral anticoagulation has been shown in the patients with AF. And this has been recently published, in which even with the modified dose, the risk assessment has been done, and it is seen that the oral anticoagulants, they are acting better with the stroke, for the stroke, and for the major bleed in patients not in the standard dose but also in the modified dose. The cumulative incidence, the and this, in this particular study, the comparison has been done with the standard dose and with the modified dose for the stroke, and the various comparisons from the real world has been shown that the dabigatran has performed better in patients with the elderly population with dabigatran as compared to rivaroxaban, not only for the stroke but also for the major bleed and all-cause mortality. They are all better. The dabigatran has performed better as compared to rivaroxaban and as compared to APVIC. So in the real world study, the patients of more than 75 years initiating oral anticoagulation for AF with standard or reduced dose NOAC has been associated with similar risk of stroke with warfarin and the lower risk for the bleeding. So the NOAC can be considered as a safer option in patients of elderly age group. So in this particular study, the dabigatran of 110 and 150 has been compared with the matched warfarin users. And in this study, the patients were mainly, the primary outcome was the first hospital admission or emergency room visit. And if we see in this particular slide that even in the patient of less than 75 or more than 75 with the modified dose, the risks are similar and benefits are similar, and it has been seen the GI bleed is a little higher in the elderly population. So from this study, it has been concluded that the older patients treated mainly with 110 milligram dabigatran dose experience less intracranial bleed and events under dabigatran treatment when compared to warfarin, but are at higher risk of cardiovascular bleeding events. This has the ACS cases has already been discussed by the previous speaker, so I will skip on to these slides in the interest of time. So in the valvular AF cases, particularly in the TAVR cases, there is a case series, next slide, in which the newer oral anticoagulants have been used in view of the various risk factors, like the patient has refused warfarin or there was a history of GI bleed. So in this case series, now this has been considered as a feasible option even in patients post TAVR also. Next slide, please. In this meta-analysis, which has been shown that in the valvular AF, the patients which were enrolled in various trials have been shown that it is a feasible option with the similar mortality, and there is less risk as compared to vitamin K antagonists. So in particular, though as of now in valvular AF, the in valvular AF, however, it is not indicated to have a to prescribe DOAC, but now the literature is moving toward the fact that in near future, yes, the DOACs will be available and recommended even in this particular scenario. So NOACs have been shown to be superior in reducing the stroke and systemic embolism, even in valvular heart disease, but not major bleeding and all-cause mortality. So in future, yes, definitely the things are going into that direction. With more data, we may be having data in this particular scenario also. And except in patients of post-TAVI as of now, in which it is clearly recommended to not to use DOACs in this particular scenario. Thanks for your patient hearing.
That was very good, Dr. Satbir.